All right, why don't we start? But this time, I think all of you know that my name is Sanjay Mehrotra. I'm together with Sait and Kishi hosting these webinars that we started on behalf of Health Application Society. This is the 5th in the series, and as you could probably have noted by now, that we are trying to bring in some of the most decorated, illustrious researchers who have contributed a lot towards growing applications of operations research and management sciences in healthcare. This happens every Friday. Sorry, not every Friday, every 4th Friday at noon Central Time. I'm in Chicago, so I just go with Central Time. And we have many speakers lined up for the rest of the year. So I hope you can block your calendar for till October of this year to join more and more of these events. Today we have our wonderful Erbu Bish, somebody I have known for a very long time. I won't say how, but you know, I have very fond memories of Erbu. I've seen her grow over her years in her professional career. And of course, she led the Health Application Society last year, I think, Erbu, right? So we would like to hear from Erbu about her work in public health screening, put more broadly in terms of seeing what the future challenges are and what opportunities there might be for, you know, old people like me. Erbu, it's all yours. It's all yours.
Thank you, Sanjay, for the wonderful introduction. And I will say how we know each other because it's important to me. So Sanjay was my professor at Northwestern and D50-2, nonlinear. So I have known Sanjay for a really long time, and I respect him not only as a scholar and an educator, but also as a person. So thank you for the introduction. And thanks, Sait and Kishi, for organizing this wonderful seminar series. And of course, to the HAS leadership for their support of this. So I first came across, discovered the Health Application Society when I was a junior faculty member like Sait and Kishi. And I really felt like I found my home. And it's been many years. I will not say how many, but I still feel that way to this day. This is an amazing society, and it's so nice to connect again with our members. So I'll talk about public health screening, quite timely these days. And the screening context I will talk about involves a large testing population. And then these subjects are usually tested through specimens such as blood or nasal swabs collected from the subjects. So often each specimen has sufficient material, so multiple tests can be conducted. And then as we shall see, this specimen testing actually provides the tester with a lot of flexibility. So makes the testing design decision a bit more complex. There are lots of application areas, and the ones that I list today actually kind of show my journey through time in public health screening. So I started with donated blood screening, which involves screening every unit of donated blood for a large set of transfusion transmittable infections. And this includes not only established infections such as HIV, hepatitis B and C that everyone is familiar with, but it also includes emerging infections such as West Nile virus, Zika, babesiosis, and many more. And in this case, actually, these 3 emerging infections are also happen to be vector-borne infections. So in general, this type of using specimens is used for infectious disease screening. And again, I worked a lot in each context area from sexually transmitted diseases to now we are seeing respiratory diseases. And also it's also used for testing for genetic disorders. And I will talk about newborn screening. So So I know we have been focused on COVID quite a bit, but there are many other diseases that pose a public health threat, and their prevalence is also increasing. So before COVID, we used to think about also sexually transmitted diseases, and the big three in the US are gonorrhea, chlamydia, and syphilis, and their rates are on the rise, have been reaching record highs. Vector-borne diseases, with the climate change especially, the vector populations, tick populations and mosquito populations are expanding. And with larger vector populations comes vector-borne diseases. And as I mentioned earlier, all of these emerging diseases, West Nile virus, Zika, and babesiosis, the transfusion transmittable infections, are actually vector-borne diseases. So there are a lot of other contexts for public health screening. Newborn screening is a big one. It's a relatively recent initiative in the United States, and it involves screening every newborn in the United States for a large number of genetic disorders. This is done through a dried blood spot collected from the newborn at time of birth, routinely at the hospital. And newborn screening is conducted in all the 50 states and the District of Columbia. It has been a major public health success, but there is still a long way to go. Just to give you an idea, in 2003, most states screened for only 6 disorders. Today, all states screen for at least 29 genetic disorders, and there are around 60 disorders recommended for newborn screening. So needless to say, public health screening is very important. It can save lives. Poor screening policies have severe consequences. And in all these application areas, I'm really talking about large-scale screening. So this is going to be very important from a resource allocation point of view. So there are some common characteristics of these application areas. Again, just to recap, it always involves, in this context, large testing populations. And we would like to test each subject for a binary characteristic. In this case, it is the presence or absence of a disease or a disorder, for which it's important that early detection is actually beneficial. And again, I'll be talking about specimen testing, in vitro lab testing, and testing resources are always limited. And in all these applications, there is a lot of uncertainty. Parameters are highly uncertain. And this type of screening is actually done for 2 main purposes. Number 1, classification of each subject as disease positive or disease negative. And the second purpose is surveillance. But today I'm going to talk about classification aspect. So from an OR perspective, there are a lot of really important research problems, and they range from disease selection to test selection to testing design. Because of the specimen testing, we could do individual versus pool testing, for example. We could use multi-tier testing and set some decision rules or thresholds which connect these testing tiers. Or we could do risk-based testing or non-risk-based testing. So there are lots of dimensions of this testing design. And they all have an impact on the important metrics in public health screening, which are classification accuracy, efficiency from either a testing resource or a testing budget perspective, equity, because different subpopulations might have different disease characteristics, and robustness, because a lot of these problem parameters are uncertain. So this is quite a complex set of decisions. So as a disclaimer, I am not an expert on testing technologies nor the biological processes that I'll be talking about today. That's why I always like to collaborate with subject experts. So really, I have learned a lot from my research collaborators, coming from American Red Cross to North Carolina State Lab of Public Health, New York State Department of Health. So they are the subject experts. I am just a consumer of that knowledge. And I also have worked a lot with Doug and Syed. So thank you to everyone. And today, my talk will draw upon a body of work that I have conducted with several former PhD students, especially Hussein, Salome, Kurayar, Hadi, and currently Marijan. So thanks. This is really our joint work. Okay, so this is kind of the outline. I will try to touch to every aspect important in screening, as well as the complexity of these public health screening schemes. Okay, so let me start with biomarkers. So biomarker measurement is used for detecting infectious diseases or genetic disorders. For example, for genetic disorders, we could search for the mutation that causes the genetic disorder directly from the subject, or we could search for biomarkers that are modified by the disorder. On the other hand, for infectious diseases, we could search for the genetic material from the virus, or we could search for antigens or antibodies. So as you see, genetic testing is actually very important in public health screening. And the PCR method is actually a commonly used technology for genetic testing, especially the nucleic acid amplification technology. And I just want to give you an example because the technology will be important in the problems. This is just one example, one picture of a PCR machine. So these are highly sophisticated testing machines, which are also very expensive. Their throughput is very low. Their capacity is limited. And for example, for this type of a machine, we have trays. And each tray has a limited number of wells. Around 96 wells is common. There are a lot of variations, but 96 wells is common. So how the testing is performed is the tester puts either one specimen or a group of specimens in each of these wells, along with an assay. And then puts the tray back into the machine and runs the machine, and it takes a couple of hours for the machine to run. So they are highly capacitated, constrained testing machines. So with that, I am going to start with challenges in newborn screening, knowing that every challenge is an opportunity for OR researchers. And I am going to use cystic fibrosis to illustrate some of the issues in newborn screening. Cystic fibrosis currently is included in newborn screening in all 50 states and the District of Columbia since 2009. So every state tests for cystic fibrosis. It's a fatal disease, and it has various manifestations from lung to liver disease. Unfortunately, it has no cure, but early diagnosis can substantially improve the quality of life for the newborn, so it's very important. So one way these public health labs detect cystic fibrosis is through searching for CF-causing mutations. So it's important to understand some characteristics of this disease because I'll be talking about a mutation search. So I will first say that this is an autosomal recessive disorder, meaning that in order to be CF positive, the newborn needs to inherit a CF-causing mutation from both parents. So if they inherit only one such mutation, this makes them an asymptomatic carrier. Now, please note that while the CF prevalence is low in the US, the carrier prevalence is quite high, actually, 1 in 31. But the main goal of CF newborn screening is to actually detect the CF positive cases, but not necessarily the CF carriers, because that would overwhelm the testing resources. These are asymptomatic people. And then in addition, there are privacy concerns. So there are lots of important trade-offs in how we go with variant selection. Now, before I talk about the mutations, PCR, or the mutation panel test, is a commonly used test for newborn screening, CF newborn screening. And I already talked about the limited capacity, the high cost, the low throughput, but it also has a panel size limit. So around 90 panels, 90 variants is common. So meaning that a panel cannot search for more than 90 variants. Now, this is very relevant because the number of CF causing mutations as of today is 382, and it is continuously increasing. This is a very active research area. When I started this research just a couple of years ago, we had around 310 known mutations. Today, it is 382, and it's increasing. So there are a lot of important questions about how do we select the variants to search for. Now, another challenge is high uncertainty. CF is already rare. Some of these variants are quite rare. The population demographics is changing. So racial and ethnic groups have different mutational profiles, and we have small and censored data sets. So again, this is a very nice example to demonstrate the importance of each of these 4 dimensions of screening: accuracy, efficiency, equity, and robustness. I'll start with, I'll talk a little bit about the non-genetic biomarker used for CF detection. The one that is used in the US is the IRT, because CF tends to elevate the IRT level in blood. However, this is a non-genetic biomarker. However, IRT is not a perfect biomarker because, again, I am going to refer back to the biological characteristics of these biomarkers throughout my talk today, because it's very important for optimization. So IRT can be perturbed by non-CF related factors. For example, it can be perturbed by external factors: temperature, humidity, reagent kit calibration, which are common for newborns tested on the same testing period. But it is also perturbed by newborn-specific factors such as birth weight, race, gender, even the prematurity status. So just to give you an example, this histogram is based on our analysis of a 5-year newborn screening data set from the North Carolina Public Health Lab. And it actually shows that this is the IRT values and the frequency. And the African-American group actually has a very heavy tail compared to all the other groups. Here we are just seeing the Caucasian group. So African-American group tends to have a heavy tail and statistically significant levels of higher average values for IRT. So that has a lot of implications on the IRT thresholds used for CF screening. So now at this point, let me summarize the screening tests that are commonly used for CF newborn screening in the US. I already talked about the non-genetic biomarker, the IRT test. It is a low-cost test, but it's also a low-efficacy test, as I discussed. But it is the first-tier biomarker test used throughout the US. Now, this has a lot of implications on the accuracy of CF screening. On the genetic side, when we search for mutations, there are 2 common genetic testing technologies used. The mutation panel test is what I discussed, the PCR-based test, but it comes with a panel size limit. So I can only search for a limited number of variants, and it is more expensive than IRT. On the other hand, one could sequence the entire CFTR gene, but this type of sequencing is much more expensive than even the mutation panel test, and the throughput is very, very low. Therefore, this is not commonly used as a CF screening test. Now, there is a diagnostic test, which is the sweat chloride test. It's the gold standard test, but it is expensive. It is performed at a specialized testing facility, and it is actually not uncommon for this test to be repeated multiple times, so it is not feasible to be used as a screening test. So at this point, so now you might be wondering, okay, how do states test for CF newborn screening? The guidelines are not specific, and each state actually comes up with their own testing design for CF newborn screening. The 2-tier, what we call the 2-tier testing design, is the most common. And what this does is, so it's used commonly in a lot of states, and this uses the biomarker, the IRT, followed by that mutation panel screening. And then if at least one mutation is discovered, then the newborn is referred for the diagnostic testing. Well, some states use 3-tier testing design, and again, the same IRT and MP, but it is followed, again, if 2 mutations are discovered, then the newborn is referred for diagnostic testing. But if only 1 mutation is discovered through the MP test, a genetic testing, entire genetic sequencing is performed on the newborn. Again, a lot of states use these technologies in different ways. Now, you might be wondering, okay, the thresholds are very important, and what type of thresholds do the states use? Starting with IRT, there is no common IRT threshold. States use different methods, different values. Going to the second genetic testing, the mutation panel, there is no common variant set used for mutation panel. As I told you, there are 383 as of today, CF causing mutations, and so one needs to make a decision. The American College of Medical Genetics recommends a 23 mutation panel, but again, states use different panels and different panel sizes. And a lot of actually these decisions are made based on descriptive analysis, very little predictive analysis, but a prescriptive framework of how to optimize a CF newborn screening testing design along with the thresholds is lacking. And it would actually be a very nice contribution to this, to the knowledge base in this area. So with that said, now I'm going to discuss some of the, again, testing design related issues here. Let me first start with the IRT test for CF newborn screening. So we actually showed that none of the IRT threshold methods that the states are using commonly are necessarily optimal from a classification accuracy maximization perspective. So we did develop a risk prediction model and risk prediction optimization and risk threshold optimization model, which we showed was optimal for maximizing classification accuracy. So there is a risk prediction component and there is an optimization component. So our risk prediction framework produces not only a point estimate for each newborn for risk, but also an uncertainty region, because as I told you, a lot of these parameters are highly uncertain. So I just want to show you the results through a case study based on data from the North Carolina State Lab of 5 years of newborn screening data. So you can see that we applied a robust optimization framework as well as an expectation-based optimization framework. And I am showing you the sensitivity versus specificity of this framework. And these are the models that we are proposing, and that is really the Pareto efficient frontier. And these are the threshold methods that are commonly used in practice. And with some states, what they are using is marked on the curve. So we can show here that based on real data, we can improve both the sensitivity and the specificity of this first tier IRT testing. So this has a lot of implications upstream for the next screening tier of genetic screening. At this point, let me shift my focus to genetic testing design. I already talked about the mutation panel. I already talked about the need to select a variant set, so the variant selection problem. So here, the main objective is to determine an optimal mutation panel, a CF causing variant set among the all known CF causing mutations. And the objective is to minimize a function of the false negative probability. Because a false negative probability means a missed CF case, so it has a lot of consequences. Now, in this context, all the false positives are rectified or resolved by the diagnostic test. So they just contribute to the testing cost, which we incorporate in terms of a CF testing budget. So they are also included, but the main focus is to minimize the missed CF cases. So we are interested in robust solutions as well as equitable solutions. So I'll talk a little bit more about that. So there is a lot of mathematical models. These are very difficult problems, MP-hard problems. So we analyze structural properties. But I'm going to share with you the results of a case study based on New York's data. So I am showing you the testing budget versus the average false negatives per 100,000 newborns. This green is showing the New York's panel, New York's 39 variants that they have been using. And we tested it, we compared it with our robust solution and the expectation-based solution. And one important thing that I want to point out here is that compared to New York's panel, we can actually improve both the testing cost. So we can do our testing with a cheaper cost at a cheaper budget, but also we can also reduce the false negatives. So this really shows the advantages of an optimization-based, in fact, a robust approach, because there is a lot of uncertainty in invariant frequencies. So now that was the robustness aspect, and this is the efficient solution, which just minimizes the false negative probability in the overall US population given here. But as I mentioned earlier, different subpopulations, racial ethnic groups in the US actually have quite different mutational profiles. And as you can see here, one of the subgroups was put at a high disadvantage by just focusing on the overall population. So their false negative probability was very high. So we focused on, instead of a robust formulation, we now added an equity dimension here. So how can we make this classification accuracy or the false negative probability more equitable among these different racial and ethnic groups? So as we all know, there is a price of equity, right? When you focus on equity, the overall false negative probability might increase a little bit. That's the price of equity. And again, this is our case study, this time based on the North Carolina data. But the price of equity was very low in this case. But as you can see, it really improves the false negative probability across all these racial groups. Now, this is actually very important because the equity aspect of genetic testing is actually not considered in a majority of the states. There's only a handful of states that use equity, consider equity, but only heuristically. And we actually show that our optimization model can also improve that. So it's also important to focus on equity in genetic screening. So I am now going to shift my focus to efficiency. And I know that we have been hearing a lot about pool testing or group testing with COVID, but actually pool testing is quite an old concept. It originated in World War II for syphilis screening in military inductees. Actually, it was the idea of an economist named Dorfman, and this is Dorfman's actually original idea. So this is what he proposed. So instead of, again, remember, we are testing everything through specimens, right? This is why pool testing is possible. So instead of testing every specimen individually, why don't we group a number of specimens from multiple subjects, put all of them in a testing pool, like here, and then use only one test on the pool. If the pool test outcome is negative, we stop testing and we declare that all subjects are negative for the disease. If the pool test outcome is positive, then in Dorfman's scheme, we follow up by individual retests of each individual, each subject in the pool, and then classify based on the individual test outcome. So this is only one possibility. And then as you can see that if the prevalence rate in the population is sufficiently low, actually this is very, very efficient, right? So most of the time, only one test would suffice. And this is actually, to this day, this is the most commonly used pooling scheme in industry. A lot of different applications. There are also lots of really other nice ideas, and I just want to show one different idea. This is known as array pooling or matrix pooling. So in this type of pooling, we put each specimen in a certain location of the matrix, row and column. And what we do is we do row pools and column pools. Now you can see that this is different actually from Dorfman pooling because now every specimen is in an overlapping pool, a row pool and a column pool, right? So then given the row pool outcomes and the column pool outcomes, either we retest or we stop and classify. So there are, again, lots of possibilities, but these lead to efficient schemes. But optimization is very important because for Dorfman pooling, for example, one needs to come up with an optimal pool size. Okay, so now, how does pool testing help with genetic screening? So going back to my example of cystic fibrosis screening, you can imagine, I already told you about the panel size limit. I cannot search for all known CF causing mutations, and that's a challenge. So you can imagine that if I want to increase the number of mutations to search for, I can just add another panel, right, and search for another 90 variants if I want to. But what this does is, if I'm doing this individually, then it just adds one more test. So it's not very efficient, but it increases the accuracy and it increases the equity because it increases the number of variants that I'm searching for. Now, to make this efficient, I can actually combine this multi-panel testing with pooling, which now serves to make this efficient. But so again, think about one panel. So a pool of specimens that I put in one well, and then test for one panel. And then I put another set of specimens in another well of that tray and search for another panel. So this can make it quite efficient, but the pool sizes need to be optimized carefully because it depends on the prevalence of the variants assigned to each panel. So this was our idea for CF newborn screening, to actually test the specimen from each newborn for all the panels, but to have a multi-panel testing and each panel is pooled. So this is quite feasible given their current technology, but this is not done. Again, what is done currently in practice is using only one panel with one assay, which is subject to a panel size limit, which is tested individually. So again, this leads to novel testing methods in CF newborn screening. But from an OR perspective, it actually leads to, this is really also very, very interesting, is that it leads to novel and combinatorial decision problems because I already talked about the variant selection problem. And I already told you that this is a very difficult problem. Now, on top of that, we are adding, so we still have a variant set, variant selection, but now I am partitioning this variance among the panels. So there is a partition decision. In addition, now I'm determining a customized pool size for each panel. So you can appreciate that the problem just gets more complex. Again, we did a lot of analysis trying to come up with effective algorithms for this difficult problem. But I'm going to share again the results of our case study, this time with New York's data, CF newborn screening data. So I am showing here the number of variants in my variant set that I'm searching for versus the genetic testing cost per newborn. So this green curve here is what New York uses currently, right? One panel individual testing. So you can see here that when I fix the variance set, actually my false negative probability is the same because I am searching for the same variance for all specimens. But the testing cost actually varies a lot. So now just look at the black line, which is only adding pooling to that one panel. So this is the current practice, one panel individual testing. If I only add pooling to that, still keep it to one panel, you can see that I can search for more variance efficiently. So the testing at the same testing cost. If I just add one more panel, only 2 panels and pool testing, I can even make it more efficient. So it has a lot of implications, and it is actually a feasible testing technology with what they have currently. And it also leads to novel testing processes for CF, because I already mentioned that currently a majority of the states use IRT, followed by the genetic testing. But the IRT is the weak link. It's low cost and low efficacy. So we envision a newborn screening process where actually one can simply replace IRT with our pooled genetic testing, multi-panel testing, or we could actually replace the MP with the pooled testing. And we actually show that these new processes actually outperform the current processes. So now we are working with New York on implementation issues, because mathematical modeling is different from implementation. So we are really now talking about discussing more detailed implementation issues with them of this technology. Okay, so now I want to just very briefly now shift my focus to infectious disease screening. I already mentioned several biomarkers for infectious disease screening, including the genetic material from the virus, antigens, and antibodies. So I am showing you some biomarker loads here for hepatitis B here, HIV here, and actually this is for COVID that Said actually came up with. And I want to illustrate a couple of points, which is very important. So again, the point here is that when we go to optimization, it's really important to understand these biological processes, right? So the first point that I want to make is these graphs are all showing the time after exposure, right? The time after infection. First of all, the different biomarkers have different patterns. The first biomarker to increase to detectable levels is always the viral load, which is the green curve here, the purple curve here for COVID, and then the solid black line here. So the viral load is the earliest to detect. The second point that I want to make is, please notice that these are all continuous. So what we measure is something continuous, and we actually convert it into a binary, positive or negative decision through a detection threshold, which is actually a decision variable. So we have some control on the test sensitivity. Similarly, I talked about this in the context of IRT, right? And the IRT threshold. It's a very similar concept. Number 3 is that these are all based on clinical data, and these are averages, but they are stochastic and they fluctuate from person to person. And I talked about these fluctuations in the context of IRT. And of course, these are also stochastic. And the last point that I want to make is that, which is very important for testing design, is that if we are going to use different biomarkers, they are actually correlated. They are not independent, right? They go through different patterns in a correlated manner. So why is it important to understand these characteristics? And I'm going to just demonstrate through a simple optimization model. This is the viral load progression. And for a lot of infectious diseases, this is the mathematical model that's commonly used, because this is the load from the virus, the genetic material from the virus. And for infectious diseases, most infectious diseases, there is a doubling period, there's a ramp up period, there's peak, and then it declines. So it's important to fit mathematical models for this. And I'm just going to give one example. I talked about pooling. For pooling, pool size is very important. So pool size optimization, how many specimens do we group? However, pooling suffers from what is known as the dilution effect. So it reduces the sensitivity of the test. So why is that? Let's say this is my viral load and this is the post-infection time. And let's say this is my viral load for a single individual testing, right? And this is when I start detecting the time. This is the window period. But when I do pool a lot of subjects, the viral load in an infected subject actually might be diluted by the infection-free subjects. And what happens is that it extends the window of period. So now it takes a higher viral load to detect the presence of a disease. So as you see, this has a lot of implications for pooling optimization. So we actually use these mathematical models of the dilution effect and the viral load in pooling optimization in a series of papers. So it's really important to integrate our optimization models with these actual biological processes. I guess this is the point I am going to make just throughout the talk today. Okay, the last point that I want to make is, so far, I assume that we have a homogeneous testing population. Everybody has the same risk. This is not necessarily the case. Oftentimes we have heterogeneous testing populations, and some risk factor data actually might be available prior to testing. So now I'm going to just very briefly talk about the benefits of actually risk-based screening. So let me demonstrate what happens to a simple pooling optimization model when everyone has a different risk, or the different groups have different risks. So in a homogeneous population, again, there was only one decision to make, the pool size, right? But now if each subject, let's say, has a different risk, let's say a probability of positivity is different, and tests are always imperfect because, as I talked, there is a window period. Now the decisions become quite complex because in addition to, now I have to decide which subjects to test individually, which subjects to test in Dorfman pools, and with what pool sizes, because I could now customize the pool size based on the risk characteristics. And then here, I was looking at maximizing classification accuracy either overall or based on the subgroups, like the acuity. So, for example, let's say I only have 5 subjects, but they are no longer homogeneous. They are all different. They all have different risks. How do I test them? Either I can, for example, put the first 2 subjects in one pool of size 2, the 3 subjects in a pool of size 3. But as you can see, this is a partition problem. It's NP-hard. There are lots of ways of doing this. Again, so by analyzing some structural properties, we came up with some quite effective algorithms. And I just want to show you very briefly the benefits of risk-based screening, this time focusing on chlamydia, which is a sexually transmitted disease. And this is based on a Monte Carlo simulation. So the blue curve is the result under a homogeneous population assumption. So I am only selecting one common pool size. Whereas this orange line, orange curve, is based on risk-based screening. And you can see that it's a win-win situation. Even just using simple risk categories, we can not only reduce the expected number of tests significantly, we can also improve on the false negatives, false positives, and even acuity. So, now with COVID came more challenges for risk-based screening. And again, I just want to illustrate based on a simple problem. So now, let me go to the next one. So now, in addition, we actually have a limited number of tests because testing is a scarce resource for COVID. And actually now each subject has multidimensional risk. For example, just to simplify, each person might have a different probability of positivity, but also a different harm. And when I say harm, it in a very generic sense, this is the harm if the person is not tested and diagnosed. So it could be the disease spread. It could be the medical consequences if the person is not treated, however you define it. But again, so we have a multidimensional risk estimate for each subject, and we have a limited number of tests. So this leads to different objective functions, right? So we can maximize the testing coverage, or we can minimize the harm, or any other combination. But again, the testing decision also becomes more complex, because now which subjects to not test is part of the decision. So maybe I am not able to test everyone. So the decision just becomes more complicated. But it provides benefits. Again, very briefly, this is based on real contact tracing data for COVID. And the blue curve is our harm minimization solution. This is a heuristic, by the way, because it's a difficult problem. The gray line is our coverage maximization solution. And the green line is what was done in those case studies, basically symptomatic individual testing in 2020. So I'm showing here, this is based on a simulation. I am showing here the coverage of the different policies versus the expected harm. So we can see that by using optimization and risk-based screening, we can actually substantially improve coverage, but also improve the expected harm. Here, the lower, the better. And very recently, we actually extended this work with Said to COVID screening on a college campus. And again, here, the risk-based screening involved based on vaccination status, right? Unvaccinated, fully vaccinated, and boosted. And we again show that there are significant benefits of using customized screening. So I just want to tell you that there are lots of really, really nice, interesting OR problems in pooling. This is another example. So array pooling, if you remember, it becomes more complex. Again, let's say each subject has a different risk. So they are not the same. They are not homogeneous. So now the question is, which subject to put in what part of the matrix, because this has implications. And I remember we were doing row pools and column pools, the test, but also the difficulty here is that the row pools and the column pools, the outcomes, the test outcomes are actually correlated. So one really needs to model that. And we also modeled the dilution effect in this paper. And similar issues arise in donated blood screening. Again, we face similar problems, and I have spent a lot of time when I first started this research on donated blood screening. Again, similar questions: which infections to screen for, how, with what types of tests, what types of biomarkers, and pool testing or not, what pool sizes. So very similar questions. So with that, I think I'm going to stop here because I already talked a lot about a lot of different aspects. And thank you again for giving me the opportunity. And I welcome questions at this point.
So just to keep things orderly, for those who actually have questions, if you can put your questions in the chat box, that will be great.
And maybe everything was very clear. Possible.
Well, that was a great talk.
Thank you.
Yeah, let me ask you a quick question here. So clearly your slides showed that there's a great benefit in pooling. And you said that you're working with New York in terms of trying to put some of this to practice, if you like, right? Because you know, I guess the concept's been around for a long time. Last 10 years, you've worked hard on it, probably longer. So tell me a little bit more on the roadblocks that you've seen, because I think that's going to be very valuable for many people. That you faced, right? Where you have lots of papers in medical statistics, and your papers in OR and IIE transactions and management science and whatnot. And you're working with real data. Where are we lack? I mean, I wouldn't call it lacking. I would say, where is the bottleneck, right?
Right. That's an excellent question, Sanjay. And of course, you know this also very well. There are roadblocks. So first of all, I think this is a process. Putting this into implementation is a process. It takes time. So it's not quick. But I think so it really helps to publish not only in OR journals, but also in the journals that our audience reads, such as the medical journals. That's actually why, for example, I didn't talk about that, but we published for babesiosis our results in Transfusion Journal, because this is a journal that actually applies to them, right? But it is also important to reach out to practitioners and to work with them. So I have been collaborating with all these people, and they do not only provide me with data, but they also tell me, okay, this makes sense. This does not make sense in practice, right? This is implementable. This is not implementable. So it's really important to work with them. And actually right now we are, I think New York is convinced, but now we are working with them on implementation issues. And as you know, implementation requires, okay, what are the workflows in a lab setting? How do you change the lab protocol, right? How complex is this in real life? So basically, right now, we are working on it, but it does take time. But one big obstacle I have to mention is that when COVID hit, everything was put on shelf. Everything changed because the New York lab, all these labs, they also screen for COVID. So, or do genetic sequencing for
They're all
COVID.
doing PSR screening. So as long as the technology can be used for other things, that's what they would do.
Exactly. And actually, New York is sharing their PSR machines with COVID genetic sequencing and variant searches. So that is what they are occupied right now. So COVID really stopped these efforts, but they are still interested, and we are working on it. So I would say it is a process. It's an implementation process.
So, I mean, tell us a little bit more. I mean, so clearly it is a process. You're collaborating with somebody in the lab.
Right.
And you did say that it requires to change the lab processes and lab protocols.
Yes. Right.
I think the audience is going to be very, very, I think, enlightened to know what is it, what does it take to even go down that far in terms of trying to get the protocols changed and the processes changed, and there's again a level of detail here, right? Which is very valuable to know.
Right. And I will just, I brought back this picture because again, I mean, I talked about the testing machine, but this, while this is feasible, this type of pooled genetic testing and multi-panel, and it's highly beneficial. Actually, it really involves changing the process because it's kind of complicated, right? So now we need to put in the different wells, different pools of specimens with, and each panel has a different chemical reagents and assays. So we have to put that in the well. So we must have a combination of these and, run the testing process. So, so this requires, it is technology-wise, it's feasible. But again, implementation-wise, they have to rewrite their lab protocols if they are interested.
So right? Is it manually done right now? So somebody is taking a pipette and then trying to use it to drop the reagents and. and try to do it that way, or is it all automated? Because that's the
That's
level, there's the
right.
cost involved, right? So there's a cost of reagent and we
Absolutely
can save the number of tests,
right.
but there's the human cost involved in actually getting a more complicated protocol implemented correctly. And that again leads to newer problems, like they can make mistakes. And once they make mistakes, what do? Can you identify those mistakes?
Right. That's an excellent question. And I would again say that a lot of this depends on the technology, but the technology exists for robotic arms.
Robotic
So
arms.
robotic arms, it certainly exists such that all these kind of collecting the specimens, each specimen has a lot of material for multiple tests. So taking a little sample from each specimen and placing it here in however way you want actually can be automated, and it is automated in a lot of places.
Wonderful.
So that's why I say it's technologically feasible, but again, it really involves a lot of pilot implementation, right? Pilot testing in practice, and assessing it.
Human errors can be a big deal, right? So unless you
Absolutely.
really have an automated equipment, the more complex protocols just
right.
get into that human issue, right?
It is
like
very
like any other thing, even COVID, right? At the
right.
end of the day, it is humans that drove the whole thing than
Yes.
than the technology, right?
Absolutely. In fact, I'm just going to say that when I started my research on blood screening for transfusion transmittable infections, the biggest, the major cause of error is not the testing error. It is human error, which is known as the wrong blood in tube. This is documented. So at the site of transfusion, the nurse, there are two Mr. Smiths using the wrong blood tube and wrong, blood.
There you go.
So there are a lot of human errors, but the good news is there are robots that can do this. So, yeah.
Nice. I guess the audience is completely quiet. So since you are an expert, so maybe you have another question for Ebru.
Yeah, I mean, I'm definitely not an expert, especially in the presence of Erbu. I cannot call myself that. But and we don't have much time left. But Erbu, maybe if you can comment more about like the future of this research for OR people. Where do you think this research is going, or like potential opportunities, especially for the genetic screening? What are the opportunities of, let's say, involving the family information, the inheritance?
Right. So Said, that is definitely that. So as of now, the newborn screening, they do not collect the family information. So all we know is basic racial ethnic group information, right? We do not collect that. And of course, that could certainly help with genetic testing. But what I would say is that, remember that I talked about 60 genetic disorders that are recommended for screening. So they have a lot of, I would say, overlapping. So one could use actually the PCR test. This is what we are looking at right now, not only to test for CF, but maybe to combine it with some other genetic disorders. They could be combined, right? And optimizing, I would say that optimizing the entire newborn screening process, even for a single disorder, is very challenging. And because, why I say that is that you can say, okay, there are only 3 tests and how complex it is. But it is complex because the IRT threshold actually affects the population characteristics moving forward. So, depending on how I set the IRT threshold, it affects, do I send more African Americans to the genetic testing, right? So there are lots of dependencies. But again, I think the biggest thing is if you can combine the testing schemes for multiple genetic disorders, which is not easy. And then when I'm doing genetic testing, I'm not only testing for CF, but also searching for some other variants from other genetic disorders, kind of synergies among these technologies. It's difficult, but I think this is a very nice area for OR people. I have not done it, but I'm hoping someone will look at the entire process.
Sounds good. Thank you.
Thank you. Thank you, Said.
We are at the hour right now, so I would say let's just do a virtual clap for what a wonderful talk we heard. And it just ended right on time, giving just enough time for Q&A. Ebru, it was good seeing you today.
Thank you.
Again, and thank you so much.
Thank you, Sanjay and Said and Kushi. Thank you. Thank you.
Take care.
Bye-bye.
Bye-bye.
Bye-bye.